Order. Good afternoon, members, and welcome to this afternoon's meeting of the Northern Ireland Assembly Public Accounts Committee. We have a quorum, and so the meeting will now start its work. Members' mobile phones must be set to airplane mode or turned off. It is not sufficient to put mobiles on silent mode as they continue to interfere with the Assembly recording. This session is being recorded in video and audio and can be accessed live via online streaming either on the Assembly website or Democracy Live. Before we go through the agenda, I would like to formally welcome Ms Cara Hunter, the new SDLP member to the committee, replacing Mr O'Toole. Ms Hunter, good afternoon and welcome to the committee. Apologies then. I have apologies from Mr Hillich, who is unable to be here. Any other apologies? Okay, that's great, thank you. Agenda item 2 then. Minutes of the 14th of October, which are in your pack, pages 7 to 15. And minutes of the, or members content that these are accurate and that I sign them as being so. Your agreement? Great. Great. Okay, thank you very much. Agenda item 3 then is declaration of members' interests. At each meeting, members are required to register relevant financial and other interests in the members' register of interest. Does any member have any interest they wish to declare this afternoon? No. Okay, thank you. Agenda item 5 then is correspondence, pages 19 to 73 of your pack. And we're delighted to be joined at this stage of the meeting by Mr Kieran Donnelly, CB, the Comptroller and Auditor General for Northern Ireland, and Mr Kyle Bingham, Assembly Sport Officer, who's joining us remotely. Good afternoon, gentlemen. Can I refer to correspondence from a whistleblower at pages 19 to 71 of your pack, and a letter dated the 18th of October, pages 72 to 73 of your pack, from Catherine Clark of the UCU. I suggest that we deal with this at the end of the meeting in closed session due to the sensitivities of the letter. Members content that we move this item to agenda item 9. Great. Thank you. Members will remain in open session to hear evidence regarding our next inquiry, addiction services in Northern Ireland. And at this stage I would ask that Mr Richard Britton-Gelly, the Accounting Officer and Permanent Secretary of the Department of Health, brought into the meeting Professor Sir Michael McBride, Chief Medical Officer, Mr Brendan Whittle, Director of Social Care and Children at the HSC Board, and Mr Gary Maxwell, Head of Health Policy Branch at the Department of Health. Gentlemen, good afternoon. Can you all hear me okay?
Yes, Chair, I can, thanks. Okay,
thank you. Can I also ask that Mr Stuart Stevenson, the TOA, can be brought into the meeting? And Stuart, can you hear us okay?
Good afternoon, Chair. Yes, I can hear you. Thanks.
Okay, thank you. So I'm going to move on to agenda item 6, but before I do that, can I just take this opportunity, because I haven't actually seen Sir Michael since he has received his knighthood. Can I just take this opportunity, Michael, to congratulate you on your knighthood in the recent honours list. It's very well deserved, and I hope you're long spared to enjoy it. Agenda item 6 then is the inquiry into addiction services in Northern Ireland, pages 74 to 141. And at this stage I would like to invite Mr Richard Britton-Gelly, the Accounting Officer at the Department of Health, Professor Sir Michael McBride, Chief Medical Officer, Mr Brendan Whittle, Director of Health Care at the HSC Board, to perhaps give some evidence to the committee, and then we will take some questions. Members, just for your knowledge, before we take the evidence, could I ask members, those who are joining us remotely, if you could mute your devices, because there's quite a bit of feedback at the moment of papers rustling and whatever, which is interfering with recording, if you wouldn't mind. So members, for your interest, the Northern Ireland Audit Office Report and Addiction Services for Northern Ireland, pages 74 to 128 of your pack, the Department Biographies 129 to 132 of your pack, restricted papers and briefing preparation 133 to 138 of your pack, Northern Ireland Audit Office restricted papers questions 139 to 141 of your pack, an additional briefing paper previous coverage of Pregabalin in your pack, pages 3 to 4. So, Mr Pengelly, good afternoon. I would now invite you to make an opening statement, and then I will open the meeting to members to ask questions at the conclusion of yours and your colleagues' opening remarks. Thank you.
Thanks very much, Chair. Chair, you've already outlined the names of the team, just in case our name plaques are difficult to see. Just Professor Sir Michael's to my right, Brendan Whittle is directly behind me, and Gary Maxwell is behind Michael. Just so members are aware of who's contributing. Chair, just before I get into my opening remarks on the substance, could I just say to you and to other members of the committee a sincere thanks. This session was originally scheduled for last November, and at the time we were very grateful for the committee's recognition of the wider pressures that myself and colleagues in the department were facing at that time, so it was incredibly helpful of the committee to agree to defer this hearing. I just want to emphasise that in no way dilutes the importance of this issue in our eyes. It was just other circumstances at the time. I think we may not have been able to do justice to what is a hugely important topic, so just to record our thanks for that. In terms of the report, Chair, I think this report highlights a number of key issues and challenges which have developed in respect of substance use over the past years, including in particular the growing use of polydrugs, the misuse of prescription-only medicines, the increasing complexity of cases, the demand in substance misuse services, and the need in particular for us to get better at capturing data and outcomes from treatment services. The report also highlights the effectiveness of harm reduction services such as needle exchange and our take-home naloxone programme, the work put in to address waiting lists for key services, including in particular the substitute prescribing programme in Belfast. The report also rightly draws a spotlight on the harm caused by substance use. Alcohol-related harm alone is estimated to cost Northern Ireland up to £900 million per annum. Adding in costs related to drug misuse can bring that to well over £1 billion per annum. And whilst those figures are important and they clearly deprive other important public services of funding, the real issue is that they don't fully reflect the full cost of this issue to families, individuals and communities across Northern Ireland. And that's why for us, reducing harms caused by substance use is a key priority. Those who suffer harm from substance use are already a marginalised and vulnerable group, and this is only likely to be exacerbated by the current challenging environment and the impact of the pandemic. So we very much as a department welcome the publication of this report and the range of issues and recommendations within it. If we go back to when colleagues in the Audit Office began work on the report, at that stage the department was well advanced in updating our own substance use strategy, and a formal review of that previous strategy, the new strategic direction for alcohol and drugs phase 2, was published in January 2019. That was then followed by a pre-consultation exercise and then a formal public consultation on a new strategy in 2020. So after revision following the outcome of the public consultation, the new substance use strategy, Preventing Harm and Empowering Recovery, was launched by the Health Minister on the 7th of September 2021. And it's important just to highlight that whilst that's a departmental strategy that the Minister launched in September, prior to its launch it was agreed by the Executive, which is it's an important point we'll return to in the context of the cross-sectoral work that's needed. The new strategy is underscored by 5 population-level outcomes, but importantly the vision is that people in Northern Ireland are supported in the prevention and reduction of harm and stigma related to the use of alcohol and other drugs, have access to high-quality treatment and support services, and will be empowered to maintain recovery. This co-produced strategy took full account of the review of our previous strategy, and importantly the timing of the Audit Office work allowed the recommendations flowing from it to be factored into our strategy. It also folded in the consultation responses and direct input from service users and stakeholders both within and without government. Also colleagues across the wider health and social care sector and the criminal justice sector. But again, Chair, just to emphasise that many of the actions within the new strategy can be directly related back to the work of the Audit Office and the recommendations flowing from it. A key issue made in the Audit Office report was in relation to the resources available for this issue. So as part of the strategy development phase, the investment required to deliver the new strategy has been a sharp consideration for us. Our initial projections are that we'll need in excess of £6 million per annum from 22-23 onwards in order to progress all of the actions and therefore fully achieve the outcomes in the strategy. Again, at the risk of repetition, Chair, just to emphasise, the strategy is there, the vision, the outcome and the actions. As yet, we don't have the funding to ensure we can deliver all of the actions within that. That's an issue for us in the budget process. But that additional funding, if secured, will help address the recommendations within the Audit Office report and indeed offset the wider costs of alcohol and drug use to Northern Ireland. These funding requirements were highlighted to the Executive when the strategy was submitted for approval over the summer. And as I said, we've already begun the process of engagement as part of the budget process. We also need to recognise that ongoing work around the pandemic and particularly the recovery may impact on some of the actions proposed. And indeed, without the pandemic, we would of course be further along that process of implementation by now. As the situation eases as we move forward, services are continuing to return to a more normal footing. Staff also been able to take on board key learning from the pandemic. That changing operational landscape has served to highlight the need to build and improve in the current capacity within services and actively considered and adopting new ways of working. Finally, Chair, I just want to highlight that while the report, which I've said we have found incredibly helpful, the report focuses on addiction treatment services. The new strategy is much broader than that. It recognises the need to prevent substance use related harm and to intervene at an early stage to help stop issues progressing to the stage where individuals need treatment. It recognises that treatment isn't the end of someone's recovery journey and that we need to ensure that support is in place to help people in the longer term. Importantly also, the strategy recognises that whilst this is a health-led issue, it cannot be solved by the health sector alone. Substance use and the related harm is interlinked with wider health and social care outcomes, including in particular health inequalities, and more widely with the economic, social and environmental circumstances in which people are born, grow, live, work and age. There are overlaps and interactions between substance use and many other issues, and to name a few: poverty, deprivation, homelessness, mental health, well-being, community relations, community safety and justice, employment, economic development, trauma and the impact of our past. So to truly address this issue, we need to work collectively to tackle these wider determinants, and this strategy seeks to do that and to add value to the initiatives already in place. So Chair, that's all I wanted to say by way of introduction. I hope that's helpful, and we're very happy to move into questions.
Okay, before I open the meeting to questions, do any of your colleagues wish to add to anything that the Permanent Secretary has just said? Okay. Mr. Pengelly, I welcome the remarks that you made towards the end of your contribution. You talked about the new strategy would focus on early intervention and prevention, because obviously early intervention is both more cost effective and more effective in terms of dealing with the problem that we face here, a problem that will have been exacerbated by COVID-19 and all that has flowed out as well there. Can I just ask, are you sufficiently content that there is a joined upness across government, both in terms of regional government here at Stormont and local government, and across the even the various aspects and departments within your own department at health, in terms of the PHA and so on? Are you content that joined upness is there now? Because I think, to be fair, I'm not being critical of anyone, I think in the past it clearly hasn't been.
I think, Chair, I am absolutely content that there is a level of connectivity both within the health and social care sector, the wider public sector and society. I am equally certain that we're not yet as good at it as we could be, but my optimism in this is it's something we're getting better at. And if we compare the new strategy, I think that the key points I would draw from the new strategy to emphasise that, I think it's of huge importance that it was taken to and agreed by the executive as a whole. I think it's hugely important that the strategy contains both a vision and 5 outcomes which focus on the issues of prevention right through to ongoing support and empowerment. And I think then under each outcome there is an action plan, and if you look at the action plan, the action owners are not in any way limited to colleagues within health and social care. They go to PSNI, the justice community, colleagues in local government, as you've articulated. So I think my clear point is we're on something of a journey, I think, across the totality of public sector services in terms of connectivity, breaking down silos, working together. We're conscious of the need to improve. We are improving, but there is a way to run, and it's something we'll keep a sharp focus on.
Yeah, no, just to echo Richard's comments, Chair, I think that one of the feedback points during the review of the last strategy, which was published back in January, was a recognition by stakeholders the collaboration that had been achieved through the last strategy, the joined up working, and also the profile that had been afforded as a consequence of that right across government. Some of the consultation responses did point to the very issue that you're flagging, which is the need for better integration between the strategic and the operational. I think that we've covered that off in terms of our approach to the new strategy. Just in terms of your wider point, I absolutely agree. We have very close cooperation, but at a UK level through the British Irish Council, the Alcohol and Drug subgroup of the British Irish Council, and also with our colleagues in the Republic of Ireland through the North-South Alcohol Policy Advisory Committee, and certainly as 4 UK Chief Medical Officers, we work very closely on all matters related to alcohol and drugs, and share learning across the jurisdictions to ensure that we do take that coordinated and joined up approach. And I think you can see that manifest in the growing UK approach to issues such as minimum unit pricing, for instance, of alcohol, and the work that we've been doing on that with colleagues in the Republic of Ireland.
Thanks for those answers. And Mr. Pengillan, in terms of your answer to the question, you were saying we're getting better at it, but we're not as good as we could be. What are the barriers? And we as a committee have looked, and we have discussed this with former heads of the civil service and with permanent secretaries from other departments. What are the barriers to the potential silo approach that impedes that sort of joined upness, or has done in the past, to allow us to get to a situation where we have a much more efficient strategy that deals with this, a much more effective strategy? Because look, all we have to do is walk around, and I'm proud to represent this city, but if you walk around this city on a Saturday morning and see so many people who are negatively affected by addiction, it's absolutely tragic, and something which is clearly endemic in our society. So what are the barriers, what have been the barriers, and what can we as politicians, and we in this committee being specific about it, do to help?
I suspect there's maybe a day's debate in the answer to this point, Chair. I compress my answer as much as I can. I would differentiate. If we talk about cross-departmental working, cross-silo working, I think we need to be absolutely clear to differentiate between people issues and system issues. In my experience, the issues are not people-based. As I journey through the health and social care sector, I try to get out and speak to colleagues on the ground as often as I can. And when I go out and, for example, speak to social workers, a social worker would never think twice about lifting the phone to a teacher, to a colleague in the probation service, to somewhere in the youth justice system. They don't see organisational barriers. They see clients and service users that they're trying to help. And I think that's true of operational colleagues across all public services. They see the issue in front of them. I think when we come to a system level, and I think the truth, Chair, is sometimes the problems are caused by people in my position, that we fixate on an accountability structure, that I am accountable for what this department does, the amount of money that we get in this department. I think we need to think at an executive and governmental level about thinking about that accountability environment, where maybe a bit more prominence is given to the contribution that we make to wider societal problems, and in particular the cross-cutting outcomes enshrined in the programme for government, rather than a set of very, very narrow performance indicators. And we need to be prepared sometimes to take the trade-off where departmental or sectoral performance can dip, and I'm comfortable coming to you and this committee to give account for that. But it's dipping in the context of we're making the offset and trade-off is we're making a bigger contribution to a higher level, a more strategic cross-cutting objective. I think certainly that's the sense, the direction of travel that I'm sensing the executive are on in terms of the cross-cutting programme for government. I think it's incumbent on myself and my colleagues as accounting officers both to follow that lead and to put in place the clear signal to the colleagues at all levels within our system that this is the direction of travel we're on, and it's in society's better interest to get there as quickly as we can. Okay,
and I think we would all very much echo your last point. And as I've said, I like the vision and the focus of this new strategy on early intervention and prevention. But to those critics who would say that the strategy has taken 5 years to update since 2016, and they might suggest that the tackling substance misuse has not been a priority for the department, what would your response be to that?
I think it might. Well, firstly, I'd absolutely, place it on the record. It is a priority for the department, and I don't say this as any form of alibi or excuse, Chair, but there are a lot of things we're wrestling with which are hugely important and are very significant priorities. Now, I sincerely don't want that to come across as an alibi. I think in terms of producing a new strategy, from my perspective, it was of huge importance that strategy contained a couple of really clear foundations. The first foundation was a substantive and meaningful review of the previous strategy. It was, real and meaningful and inclusive stakeholder engagement, and then a mature period of co-production with all the players. Those are absolutely essential building blocks to get us to what I sincerely believe is a very, very powerful strategy. But they, of necessity, took time to do. It's not unreasonable, Chair, for you to say, maybe we could have done them a bit quicker, and with the benefit of hindsight, maybe we could, and I wouldn't down a ditch defending that. But for me, it was really important to get it right. Michael's part of it. Do you?
Yeah, no, very much so. I mean, I'm intimately involved in the oversight of the implementation of the strategy. It was a very deliberate policy decision by the then Health Minister that in the time frame for the strategy, 5 years as it was originally afforded, was not long enough to see the realisation of the progress that we wish to see within the strategy. We then extended that, as the Chair will know. But I think the point I would want to make is that whilst we were engaging in and we had a significant number of pre-consultation events, we had over 250 people attend to those events. We had 78 formal responses. I was present at a number of those pre-consultation events. As Richard has said, it very much involved both service users, families affected, those bereaved by communities, and looking at all of the evidence that was accumulating on alcohol and drugs right across the UK and internationally. We weren't not doing things in the meantime, just to reassure the Chair and the committee that the implementation and the rollout of the objectives and achieving the objectives when the last strategy continued. If we look back at the review published back in January, there were 1% of the objectives within that weren't achieved, and those are ones that we had set aside as being no longer relevant. 98 of them, 70% of them were on track for approval or for implementation, and 24, I think it was, or 17% of them had been fully achieved. So I think we have made significant progress in terms of the implementation of the recommendations in the last new strategic direction phase 2, and I'm confident that through the process that Richard has outlined, that we have secured the cross-government buy-in, outside of government buy-in, academic buy-in, and most importantly of all, communities and service users and those most directly affected, as you referred to, Chair. So I think we face many challenges because, as the report, the Audit Office report quite rightly points out, the complexity and challenges have become greater. And we need to recognise that. We need to not be complacent. But I do think that the new strategy puts us in a very good place for going forward.
Yeah, and just finally from me for the moment, and before I bring other members in, I don't disagree with your final assertion that the challenges are greater. I think we all would accept that's clearly the case. Richard, in terms of what you were saying about the players, all of the players, and I'm pleased that there was such a large response in terms of people being consulted on the new strategy and the input that was coming from that. But just being devil's advocate for a moment, my constituency is hugely affected by a lot of these issues. Everyone's is, but North Belfast, Greater Shankill is particularly negatively affected around all of this. And a number of events I've been at, and just in my work around this issue that I've pursued over the last number of years, I sometimes hear the argument that there are too many players around this issue, and particularly at community level. Now, I'm not saying that's my view, I'm simply being devil's advocate. What would your response to that be?
I can understand the frustration from some individuals thinking that, because at times, particularly when you're in the space as we are now with this, and indeed as we are with the wider range of services that we're providing, we're really in a co-production environment. So aside from the simple fact of having a number of service providers in the room, that also draws in relevant staff, service users, the families of service users, and at times that can crowd out the core elements of the conversation about how we actually identify the changes as necessary and give effect to it. I also think that sometimes with too many budget holders in a room, the conversation becomes more a turf war about budgets than it does a laser-like focus on the needs of service users and how we deploy the totality of the budget to that. I'm thinking maybe particularly, Brendan and Gary have been part of those lower level conversations. Gary?
No, I think it's a fair point. I think given the diversity of the determinants of substance use, there are a lot of players in the field because it overlaps with homelessness, it overlaps with mental health, it overlaps with community safety and criminal justice. And I think one of the criticisms could be that because that is such a messy playing field, it can be hard to focus and be specific. I think one of the key things we're asking out of the new strategy is that the board and the PHA work with those key stakeholders across all those groups to develop a new strategic plan, outcomes plan for substance use services, and that shouldn't just be for health and social care services, but it should look at what we're providing through community planning, what we're providing through the PSNI and other providers, and to actually pull us together to look at delivering one connected commissioning plan, be that education and information from EA or the education sector, right through to inpatient beds, where people can go in for treatment for a specific period of time. That's not easy, that will be difficult to do, but I think having that seamless one vision should hopefully help focus and reduce some of that messiness, I suppose, that can exist just when there are lots of players and lots of overlapping issues. So I think hopefully that will be key in sort of pulling that together and having one focus. We've also been quite clear in the strategy in some areas of things that don't work, and there has been some areas and places that have rolled out things that aren't particularly evidence-based, and the key thing of the PHA and the board, I suppose, leading that work but not owning that work, is about them being able to bring the evidence base of what works to community planning, to local players and stakeholders as well, around if we want to make the most difference these are the elements that the evidence shows that does, but also get that feedback from communities as well about what works well for them and what works in those areas, and hopefully build on things like community planning, which brings in those community voices. Brendan, I don't know if you want to add anything to that.
Thank you, Gary. The only thing that I would add to what you've said is that the aim of the work that we'll take forward on behalf of the board and the PHA will be that strategic plan will create the care pathway across all providers, so there is that smoother journey for service users. And our aim within doing that will be that we align both our commissioning but also our procurement across the HSE and wider, so that they're better aligned, and that makes that a smoother place and less bumpy for people to navigate.
Okay, thank you very much. Ms Hunter?
Yep, sorry, I just had a wee technical error there. Good afternoon, everyone, and thank you very much for your very important briefing. And I touched on the cross-sectoral work that is needed on this issue with addiction. And I agree, I think a joined-up approach is necessary to help with the kind of aspects of recovery that you've touched on, from housing to mental health and more. And I welcome also, you touched on the level of engagement ahead of the strategy with the number of consultations and working with service users. So just to say, that's most welcome. My question today refers to looking at the review of addiction services in 2013, it had stated clearly a regional approach to rehabilitation is necessary. But currently, we have 2 trusts which don't have proper access to rehabilitation beds 8 years later. So my question today is, why haven't these issues been addressed? What is being done to address them? And I know, being a representative for quite a rural community, there's also fierce regional imbalance when it comes to access of these kinds of facilities. So any clarity on that would be most welcome. Thank you.
Brendan, in terms of the commissioning of the services, is that?
Yeah, thank you.
So maybe I could just maybe start off, Brendan.
Sure.
Yeah. So there was, you're quite right, Karen. Thank you for your question. There was a review back in 2013, which looked specifically at the inpatient services, and again, it's 4A. I think it's the recommendation within the Northern Ireland Audit Office report. There are 33 beds in total now across the system. All trusts have access to those beds. I think what you're referring to is previously that was not the case, but they are provided in the Southeastern Trust area, the Western Trust area and the Northern Trust area, but all trusts have access to those beds as part of that sort of 4 tiers of service. There's been a huge amount of work to ensure that all of those inpatient services operate to the standards and best practice, NICE guidelines, the so-called Orange Book, etc. And what we don't have, and I think is work that has been committed to by board colleagues, is the effective integration at this point in time with the residential addiction services. And so that is work which is committed to within the new strategy. That work will be taken forward. As you know, we do have residential addiction services in Derry, Londonderry, in Northlands, and again in Carlisle House. But I think quite rightly the report has highlighted the need that those services, the residential services, weren't agreed, and there is need for a very seamless integration between the residential, the inpatient services, and right the way through from low threshold services through tier 2 services, through to tier 3 services, and into tier 4. There should be no bumpiness in that. And it's back to the point that Gary made and Brendan made, is that those care pathways need to be absolutely clear, and service users, families, communities need to know that what we are referring to when we talk about those services. So part of the work undertaken in the new mental health strategy and the action plan falling out of that will be that there will be regional structures which will oversee mental health services, not removing the responsibility from local trusts, but to ensure that there's consistency in approach, and to address some of those issues that around access and transfer of individuals between facilities. And those pathways, I think, do need work, and I think there's a commitment within the strategy that that work will be taken forward. Brendan, I don't know if you want to...
No, thank you, Michael, and apologies for the slight delay in coming in there. You quite rightly pointed out that the Audit Office report pointed out that Tier 4A services, which are statutory-based services and provide initial detox and stabilisation, were reviewed in 2013. Those 3 sites, with our own 3 trusts, are now provided on a regional basis. So any member of a citizen who needs those across Northern Ireland can access one of those 3. So they operate as a network across the 3. Likewise, those services at Tier 4B, which would be more in relation to the rehabilitation than the detoxification and stabilisation arrangements, those weren't part of the review. And they will need to be looked at as we go forward in terms of the plan, which was referred to in the last question. And I suppose one thing that I would wish to acknowledge is that all substance use services should be available on a regional basis where possible in both Tier 4A and B services. And I think that will be an essential part of the work that we bring forward to develop a strategic plan for new services. And you will understand that we will be seeking funds to further support and reinforce these services and to seek to improve the coordination and the accessibility of those services going forward.
That's lovely, thank you. And then just one more question, just touching on the delivery of the new strategy. I know there's been a lot of discussion around dual diagnosis, and it's featured within the strategy, and I'm mindful Orlia has a keen interest in this also. So I'm just curious, can you just tell us how will services adapt to the needs of those with coexisting mental health and addiction issues? Thank you.
I think at a high level, the issue there's the programme board which will work on the delivery of this, which Sir Michael will chair for his sins. That obviously will be taken forward very much in parallel with the delivery of the mental health strategy. And forgive me for making the bleeding budgetary point. The mental health strategy requires something in the order of £1.2 billion to be delivered over the next 10 years. That's still a big challenge for both us and indeed the executive. That issue will be with that. There's the action owners will look at the specifics of that. Michael, do you want to say just on that?
Yeah, so maybe bring Gary in on this as well. I think that one of the points that was fed back to us during the pre-consultation events and has been raised repeatedly through the time of the implementation of the previous strategy was the issue of dual diagnosis. And as you know, the issues of alcohol and drug addiction often go hand in hand with mental health problems. Sometimes people use drugs and alcohol to self-medicate to deal with the underlying mental health problems, and what we also know is that drug and alcohol sometimes quite often exacerbates underlying mental health problems, and the antecedents of that, the origins of that lie in sort of adverse childhood experiences and all of the environmental, cultural, family, community problems which Richard referred to in his opening comments. During the pre-consultation work, there was a lot of discussion about actually having a separate dual diagnosis service. We looked at all of the evidence around that. We consulted very widely on that, and we actually came to the view that that would actually create additional barriers in terms of access. And what we actually need is to ensure that mental health services and those working in those services and addiction services have the skill sets and the expertise to address individuals irrespective of where they present. I mean, there should be no closed doors, and there should be no passing of individuals around from pillar to post from one service to another. So the commitment within the strategy is to establish a managed care clinical network, particularly for those with dual diagnosis. The board is committed in the short term to doing a review of services available for those with dual diagnosis. The strategy gives a commitment to raise experience and awareness and also build expertise into that the managed network. And what we absolutely do need to see, and it's back to the chair's comments at the outset, we need to see very much joined up working between the oversight and implementation of the new mental health strategy and the oversight and implementation of the new substance use strategy, because these issues are cross-cutting, and similarly there's very strong links there are with Protect Life 2 and all our work around suicide prevention, because they have, unfortunately, many of the origins of these problems are in our troubled past, high levels of deprivation, socioeconomic problems, and those are the very fundamental cross-government issues that Richard referred to, that we can only address if we work at that very strategic level through the programme for government.
Mike, I would just add, I think you covered it really succinctly and really well. I would just add the other developments is around the development of the one mental health system, and we're working very closely to ensure that addiction services or substance use services are linked into that as appropriate. And it might be in due course, when implementation structures are more up and running, we fold some of this closer together to create less structure. We're not quite there at this point, but I think making sure that addiction services are really strongly referenced within that one mental health service, and particularly I think in the crisis review service work, I think it's really important if people in crisis don't get turned away because they turn up intoxicated with alcohol or other drugs, and I think that's really a vital piece that we make sure that it's linked in from there. So I think, as Richard said, I don't think it's not a personnel issue in these services in terms of dealing with co-occurring. It can sometimes be a system issue, but we're trying to solve that by bringing the two systems much closer on a regional basis, and hopefully that will show dividends in due course. But it will take time to work through, because the demand is quite high, and the complexity of those cases, as people will be aware, is very difficult.
And if I may come in on that, the only thing I would add to that point is that the reference to the regional mental health service will directly benefit patients by removing variation in services, so that everyone, wherever they live across Northern Ireland, will have access to similar types of services where they live and when they need them. It also help us, I believe, in terms of improving the movement of patients across trust boundaries, so you don't have that fall off when a patient moves from one area to another. So in my view, I think that single mental health service overlaid on the addiction service is quite an optimistic picture in terms of how we can coordinate these services better for our citizens across Northern Ireland.
Thank you. That's very positive. Thank you very much. Thanks, Chair.
Okay, Ms Flynn.
Thank you, Chair, and thanks very much to the panel for coming to committee today on what is an extremely important report for our committee. I know that just earlier when some people were commenting on going 5 years back when you were working on the new strategic direction for drugs and alcohol, I think, Gary, one of the first times I met you to talk about this was around 5 years ago. So in a way, I think it's brilliant to see how much progress has actually been made on the issue, and I do want to commend all of you in the room there for the work that you have put into this, and also I'm conscious that the Minister, obviously he has prioritised this as well, the fact that the strategy's got to the stage that it's been consulted on and now it's been published, and given all the pressures that people touched on just around COVID and stuff. So just at the outset to say, I think from the audit report had been completed and published, you can see that the department has put a lot of work into this issue. But Richard, I know that you mentioned a couple of times, obviously, the elephant in the room, the problem, facing over the next couple of years and how you progress the report is definitely going to be the funding, and that would be one of my concerns, like how realistically we can actually tackle these issues around addictions if we haven't got the funds to do that. And so my first question would be around, I know that you will be aware of the health inequalities here in the North, and Michael, I know that nearly all the briefing sessions that you and the Minister do with the Health Committee, I'm raising this with you, but we know the stats around the drug and alcohol deaths, they remain the most stark health inequalities in the North. and people are dying in the most deprived communities. You're 3 and 4 times more likely to die of drug and alcohol deaths than in the most affluent communities. And so for me, that's more than an audit office report, that's more than a strategy, that's actually lives that are being lost in communities, and that trend isn't changing. In fact, we know that it's getting worse, because we know that the amount of drug deaths have trebled over the past 10 years. So in terms of the health inequalities, how we link that to addictions and to this report and to the substance use strategy, is there anything proactively that the department can do to work alongside the Minister to try and tackle the issue from a health inequalities perspective? That's my first question. Thank you.
Thanks. And thank you just for your acknowledgement of the work that's gone into this. And if I get my own, a lot of work has gone into this. I think, as you touched on, Gary has made a huge contribution in particular to this. And I think the other three of us in the room would certainly tip our hats to Gary for the role he has played in this in particular. The first point I would make is a point that my Minister will constantly make. Health inequalities cannot be viewed as a health issue. The health issue is the outworking and the impact of health inequalities at a societal level. The way fundamentally we address health inequalities is coming at it from a wider societal perspective, come back to the cross-cutting programme for government. And I think that there is a recognition, and when we talk about some of the issues here, there being a multiple of 4 between the least deprived areas and the most deprived areas. Successfully targeting this issue, for example, isn't just about closing that gap in the sense that all it does, in inverted commas, is help the most deprived elements of society. This helps all of society. Any society needs to be measured by how it looks after those who are most disadvantaged, and there are benefits at a societal level for everyone in society if we do that effectively. The executive has certainly set its stall to tackle inequalities wherever they occur at a societal level. That will be at the heart of the programme for government going forward. That in itself gives me some comfort that the budget debate isn't all doom and gloom. We need a lot of money to address this. We talk about the £6 million, for example, that we need to deliver the actions in this. There is money at play. We're spending money at the moment, so some of that £6 million we think may come from actually recalibrating how we spend our existing money. It will also, there's opportunities, economies of scale and opportunities for synergy from us effectively working with budget holders in other sectors. If they have £100 and we have £100, I think we can get £300 worth of value from spending that more cohesively and more coherently together. But your core point about inequalities, this is an absolute essential issue for us. This is not something that it would be nice to do if we had the money. We will fight tooth and nail to get the money to take this forward, because we are absolutely seized of the importance of it. Michael, I know it's something you personally are passionate about.
Yeah, thank you for the question, and I grew up in the part of North Belfast that the chair was referring to, so I'm acutely aware of the inequalities there, health inequalities, educational inequalities, and the impacts of those, and those have got more difficult as the years have passed. And I think the one thing that I would say is that this strategy fits within the broader context, yes, of the programme for government, but also in terms of making life better, which is our wider public health framework, approved by the executive, and again representing joined up working across government to improve the health and well-being of the entire population. I don't get much of an opportunity to talk about money much. I leave that to the gentleman on my left. But I think the Audit Office report well makes the point that we estimated back in 2008 the cost of alcohol and drugs across Northern Ireland, updated that in 2014, somewhere in the region of £900 million. And if we add in the cost of drugs on top of that from pro rata from Dame Carol Black's report, that takes it up to somewhere in the region of 1.5 billion. That is a considerable cost. As Richard said at the outset, let's be very aware that that's on people, it's on families, it's on communities, but it's also cost 250 million of that to the health service, to the criminal justice system, to policing, court services, right across society. And through the vehicle of the programme for government, it should be possible for all of the permanent secretaries with their checkbooks to get around a table and agree and recognise that the individual contributions from government departments, as the Chair was indicating earlier, what difference they will make in a particular space. I mean, we have good local examples of that. We have, for instance, at a local level within Belfast, we have Belfast City Council coming together with the Public Health Agency and the Health and Social Care Board to basically take a whole system approach to dealing with the issue in Belfast, adopting a model that's been very successful in Doncaster. So it can be done. It is being done at a local level. And I think the challenges for us in terms of the budgetary pressures is to ensure that we elevate that to the strategic level, as Richard had suggested. But the figures are stark. Orlith, as you point out, the inequalities in alcohol and drugs are more stark than anywhere else. People in deprived areas are 5 more times likely to die of drug overdose, 4 times more likely to die from alcohol. The strategy itself recognises that, so it has both taken a universal approach at an entire population level, but also a targeted approach, in terms of those most at risk, those living in deprivation, as Gary said, those are homeless, those are injecting drug users, and there's a commitment within that to develop an intensive outreach programme which board and PHA colleagues will commission to ensure that we're reaching those that are at greatest risk from alcohol and drug use. This is not going to be easy. Far from it. I think we're facing into a very, very difficult time. We can only look at, if you referred to the increase in harms related to alcohol. Yes, positive indicators in terms of at a population level, but the harms associated with drugs and alcohol in terms of deaths and in terms of hospital admissions are going all the wrong way across every part of the United Kingdom, perhaps with the exception of Wales, which is a slightly more stable position at this point in time.
Maybe can I just add to that one? I think one of the key drivers of the inequalities here as well is stigma, and that came out very strongly in our pre-consultation work on the report. And actually, when Minister launched the strategy, he met with some service users, and listening to their story, they came for treatment later than they probably would because they felt the stigma of their substance use issue with their family, with those around them. And I think along with taking harm reduction, which actually really focuses on those most at risk through needle exchange and naloxone programs, that's really good at helping to reduce inequalities. But I think in the longer term, if we can reduce some of the stigma of people seeking help, I think actually we can get these people into services earlier and provide them with support that means the inequalities will reduce. I think there'll always be an inequality in this. I think deprivation will always drive some difficulties in this, but I definitely think we can do better by tackling stigma as well as some of those really strong harm reduction approaches that Michael touched on.
And that, again, was one of the strong things we heard, during the West Belfast Drugs Panel report, which, that stigma doesn't just affect the individuals, it affects their families and their relatives. And, unfortunately, what you see then is stigmatisation within a community of both individuals and their families, and then that creates that vicious cycle of almost transgenerational problems with alcohol and drugs.
Yeah, no, look, thank you very much for, you've all made really important contributions there. And Richard, I do take your point that the issue around the health inequalities, this does cut across every single department. So I think it is important for all departments and the collective as a whole to, try and prioritise these issues to try and, change some of those stats for the better. And Michael, I'm glad that you actually raised the West Belfast Drugs Panel report there too, because just the point that Gary had made around the stigma, I had took down a note about that whenever you were talking. And in a way, we know that all that stigma exists, but I think maybe to try and take a positive out of some of it, I think the fact that we've got to where we are with this strategy and with the 10-year mental health strategy, I do think that the conversation, hopefully, around mental health and more broadly generally around addiction is starting to change, and that this will, what you are doing in your work, what we're all doing collectively, will try and help with that stigma, help to reduce it a wee bit. But I think that then the bigger problem for me and for yourselves as a department and for us as a society, you had referenced it, Michael. I think the bigger problem is more around, the culture and the complexity of drug taking is changing. And, you had all mentioned that in some of your remarks, but it's then how the drug taking behaviours are changing and becoming more complex. So it's then trying to get our systems to adjust to that, which is, it's going to be a massive task, but hopefully the strategy will help with that, and the recommendations from the audit report. I wanted to come back, Michael, as well, just on when we were talking about the cost and some of the figures that was quoted around this 1 billion per year. So when we talk about the alcohol related cost to the health service, that's 900 million. I know that the department has included in the strategy that there is a need to undertake research so that you have the evidence that's going to provide the best sort of policy development. And I'm just wondering on that issue of the research, are we doing any of our own research locally actually to try and identify how much money is coming out of our budgets towards the drug use? Because I know we have that 900 million for alcohol. Are we doing any work to identify actually the cost of harms caused by drugs and drug use? And then my final question and comment is around the issue that Cara had raised around dual diagnosis. And I know the work that Cara has done on this as well, because she chairs the all-party group on addiction. And I think that I take the point that was made that because I'd spoke with officials previously on this, that a separate service might create more additional.
Can I push you for a question, please?
But I think that the problem for me with a dual diagnosis service and, with just trying to create more of a managed network with the services that we have at the minute, it's the definition. So when we're talking about the complexity changing and the nature of drug taking changing.
Ms. Flynn, can I ask you to ask a question, if you don't mind?
Yes, I'm just getting on to it. Thank you, Chair. But I think that the problem is that the dual diagnosis at the moment, we're talking about mental illness and addictions. We're not talking about mental health problems. And that needs to factor into the work of the department, because that's where we're missing people. That's where we're missing the opportunity of people that are presenting in crisis in emergency departments, and they're not getting the help that they need. So I would like to ask the question if that could be considered by the department to look at that definition, or if that's going to be part of the work with the managed care network to try and look at, so people aren't getting turned away when they're going to ED if they mightn't have schizophrenia or, bipolar, but they might genuinely be in mental health crisis and be battling with addictions. And I think that's a problem that we haven't dealt with as yet, but thank you.
Thanks. Gary, just on that second point.
I think what we've tried to do in the strategy is move away from the term dual diagnosis and move more to the term co-occurring mental health and substance use issues, because it occurs in a spectrum from issues that won't really impact somebody's mental health right up through to as somebody who has a diagnosed illness. And I think that's one of the reasons why we're a bit. Well, we think a managed care network across co-occurring would be superior to a specialised unit, because a specialised unit will focus specifically on those with the most need, those who have a dedicated diagnosis and an addiction issue, and it will get all the hardest cases referred to it, and another barrier of entry. Do you meet the threshold to go into this service? Whereas we're hoping the managed care network will be more a co-occurring care network. I think it might be called dual diagnosis at the moment, but the intention is that it's actually about building capacity in all those involved in treatment services, both in the statutory sector or in the community involuntary sector or elsewhere, to recognise the interrelation between the two issues, and how some of that might be just about providing additional little supports to people who have depression and substance use issues, or anxiety and substance use issues, as opposed to somebody who has a personality disorder, and that's a completely different level of intervention and service required. So I think the intention is of that network is to build capacity and experience and expertise, and actually bring together the workers from the two sections, because actually the skills overlap an awful lot. They are very similar skill sets. It's more about feeling confident in addressing them and making sure that you feel you have the ability to deal with those issues and pass them on and escalate the issues as appropriate. So I hope that reassures you a bit that we are looking broader than that. It does get more complicated when you don't have, when it's obviously a diagnosed mental health. You can say that's still diagnosis. When you come down, it's obviously more difficult to diagnose, but that's certainly our intention.
Okay, just on the research, if I could very briefly, conscious of time, just to reassure you that we do have a research subgroup of the existing strategy. We will there's a commitment to that in the new strategy. We have commissioned local research as well as using international research. So for instance, back in 2015, I think it was, we commissioned Sheffield University to do the research on minimum unit pricing in terms of alcohol and the impact there. We've commissioned research from the Institute of the Ireland Institute of Public Health, so looking at north-south work on alcohol density, for instance, in terms of off sales and the impact that has on alcohol-related harm and consequences. And we've commissioned a whole range of research on other issues, and certainly we'll continue to do that through the R&D office of the Public Health Agency.
I would just add very briefly that. This is the sort of performance management freak in me coming out. Your question was really about the overall cost of drug misuse. I have to be honest, that's not something that I would lie awake at night wanting to get a precise figure for, because I know it's a problem. And I know taking forward this strategy will improve lives, it will improve society. Trying to chase down a number like the overall impact of drug misuse on any given day of the week, if you do that calculation, you'll probably come up with a slightly different number. I think in the Audit Office report, they made some very, very valid points about some deficiencies in our data collection. The interesting thing in the strategy is what we've set out across the 5 outcome areas. We've set out some metrics in terms of the indicators of how we're doing against each of those outcomes. They're real tangible numbers that we can measure, and we can measure with certainty, and that's where we start to move the dial in this. So I think we might want to explore the overall societal impact. I want to really sharpen our focus on the indicators to get them moving in the right direction and to start improving the lives. And just a final point, you talk about the changing landscape, the problem is evolving. This is just to highlight a 10-year strategy with a 5-year review point, because as night follows day, 5 years in, the landscape will have shifted again, and we need to be ready to recalibrate our action plan to take account of that.
Thanks very much.
Okay, Mr. McHugh. Mr. McHugh, can you hear me? Okay, seems to be.
Hello, Chair.
All right, okay.
Well, fáilte overling, Jas will Yelsha, Tanonisha. You're all very welcome here this afternoon. It was a very nice meeting with you. I was pleased for you the righteous Foster, and thank you for your statement as well, even though that within it gives me some causes for concern too, and many of the points have been already covered, we'll say, to date. But one in particular, whenever we mentioned about the strategy that we have now developed as such, right, and yet all the funding is not in place in order to deliver it. How much of an impediment is that going to be in order to be able to meet the objectives within that same strategy? Especially when we talk about the need to build capacity and how it is that we address many of the issues in relation to drugs abuse, alcohol abuse, to address it at the very outset. How will this lack of funding impact on that?
Okay, I think just in terms of the funding landscape, the Audit Office report, I think, talked about 16 million was spent in this space. I think some of the work that we have done on the strategy, on the development of the new strategy, and it goes to my previous point about this is an evolving landscape, and if you look at it, the numbers move. We reckon that probably the more accurate figure is about 21 million. So what we're saying is we need another 6 million per annum to fully deliver the strategy. But that's in the context of something of the order of 21 million being spent in this space. So that, I say that to give you a sense of proportionality. We wouldn't be, without that 6 million per annum, we won't be able to do everything in this strategy. The money is there at the moment, certainly for us to make a good start in this and to progress it. To be fair, to be absolutely fair to the executive, this strategy was only signed off in early September 2021. So since the strategy was signed off, there hasn't been a budget process. So I don't want to inadvertently suggest that there has been a decision not to fund this. There just hasn't as yet been an opportunity to seek the funding for it. We're doing that now as part of the budget process. I think the comments today on a cross-party basis will certainly be replicated at the executive, and bearing in mind the executive have signed off on this strategy. I think we're pushing at an open door in terms of seeking to secure the funding for this. That said, the executive is under intense financial pressure, but even if we're not successful completely for the 6 million per annum ask, we have enough funding to make a good progress in terms of taking forward the actions within this.
Okay, that's good to hear. Now, in addition, just in fact, in response to other questions that you've already been asked, is there, or do you perceive, would you accept that there's a disparity there in terms of regional provision? And I'm talking here from the perspective of, we'll say, within West Tyrone, an area that I represent, totally rural in many respects, and that there is that feeling that once again, much of the funding is geared, but say, towards the greater number of people, i.e. within the more, not just urbanised, but the city areas, to be specific about it, with say Belfast and Derry.
I think there's an issue that we need to be very clear about, and in my mind, there is a difference between a debate about where services are provided and an issue about who has access to services. The position that we need to be in is that we need to be absolutely certain, with no hesitation or caveats whatsoever, that every single individual across Northern Ireland has equitable access to services where needed. But that doesn't mean that we provide every service in every location. Were we to do so, we would destabilise services. We would drive the cost of it up at a time when there isn't the money to do that. But those individual services would not be resilient, because they would be very small services fragmented across the region. In saying that, what I'm saying, the logical conclusion of what I'm saying is that we have a number of centres scattered across Northern Ireland that provide services on a regional basis. We need to look carefully at how we structure and locate those, because we need to marry up services across a whole range of areas, that we get proper geographical coverage, because we can't expect the rural community, for example, always to have to travel towards the big urban areas to access services. Sorry, that's a long preamble. Brendan, I think we'll talk just about the commissioning model and where the services are. But I'm just introducing the difference between access to services and where the services are located.
Well, sorry, just before Brendan comes in, if I could say, I'm not talking about specifically the location of a unit, but also access to the correct services from the very outset. There seems to there as well too.
Certainly.
If I may come in, certainly in terms of the funding and how that is currently spent across the HSE Trust, there is a range of funding across each trust, and that reflects the service model in each trust. So by way of example, in years 19-20, the Belfast Trust area had an expenditure of some 2.1 million, Southern Trust 1.3 million, South Eastern 2.7 million, Western 3.6, and Northern 2.8. So you will see from those figures that there is a variation, and that reflects the location of the units. Within that, I am very minded that the operation of the units as a managed network, certainly in Tier 4, is helpful in terms of seeing the access to services for people who need them. going forward, as we develop the future planning arrangements for our addiction services, we need to be mindful of the resources that we have available and how those will be best deployed to meet the objectives of the strategy.
Well, and just finally, if we can also then be more specific as well too, of particular concern is the drug pregabalin, that the north of Ireland has a much higher rate of prescription of this particular drug, despite warning to GPs to be vigilant in prescribing it. This drug is a major factor in the rise of drug deaths. Would that be your opinion? And what is it that we can actually do about that? I know pregabalin in itself is essentially a drug that is used for epilepsy and the likes of it, but yet not at the same time that it does seem to be giving rise to great concern in terms of both addiction and of people suffering more serious consequences as a result of it.
Okay, I'll maybe say a couple of comments and then Michael, as our medic, will offer a more informed view. The first point I would offer is I think we need just to tread carefully that a problem with prescription drugs doesn't automatically equate to a problem with the way those drugs are prescribed, because people can access prescription drugs through underhand measures, for example. In terms of then any analysis of prescribing patterns between Northern Ireland and other places, that needs to recognise the different health needs of the population of Northern Ireland, and there's some very stark disparities in that. I think that's the main point I want to make in terms of that comparison, Michael.
Yes, well, thank you for the question, and I think you're absolutely right to flag the issue of pregabalin, other gabapentinoids, and also the Northern Ireland Audit Office report quite rightly flags the growing problem that we have had with the misuse of prescription drugs. I mean, from 2015 we've had a very significant change in culture and availability of drugs in Northern Ireland. It's fair to say that prior to that, Class A drugs were, such as heroin, for instance, were not as accessible in Northern Ireland as they were in other parts of the UK. One can speculate as to the reasons for that. There indeed has been discussion about the role of the paramilitary and paramilitaries perhaps controlling the drug market and the impact that had on the availability of Class A drugs. And obviously we've been working very closely with the Department of Justice and BSNI in respect of that. We have seen, unfortunately, increased availability of Class A drugs, and now with emergence of criminal gangs and international gangs as well in terms of the availability of those drugs. Prior to that, and because of that lack of availability, undoubtedly in Northern Ireland, we developed a very significant problem with prescription drug misuse, which, as Richard has said, the deaths in relation to which are associated with drugs. I mean, 191 deaths in 1920. Many of those deaths associated with polydrug use, including counterfeit drugs, prescription-only medicines. Those drugs, again, sadly, predominantly in young men. And again, just to make the point that other drugs are more generally prescribed in older individuals, such as the benzodiazepines and the gabapentinoids. We did a lot of work in Northern Ireland in terms of flagging the issue of gabapentin, pregabalin. So we identified it as a problem back in 2011, 2012. We saw the increase in deaths associated with that in 2013, and indeed we flagged this to the Home Office, the Advisory Committee on the Misuse of Drugs, and I think played a very significant part in having the change in classification of the drug to ensure that it was less available. We've done quite a piece of work, as you've quite rightly pointed out, in terms of the Northern Ireland formulary, where pregabalin was previously recommended as a treatment for neuropathic pain as well as epilepsy, as you quite rightly point out. That is no longer the case, and has been relegated to a second-line drug when drugs such as amitriptyline are not effective in that respect. I mean, if we look at the pattern of prescribing over the last number of years, there is certainly room for improvement. There's no doubt about that. But the combined use of pregabalin and gabapentin in Northern Ireland is less than that in Wales. That's not to say that's a good thing, but and we're on a par with Scotland. So yes, much more to be done, and certainly that's, we work very closely with the Organised Crime Task Force, as a subgroup within that, on alcohol and drugs with the Department of Justice and with PSNI colleagues. But unfortunately, we do see opioid-type drugs, benzodiazepines, and other prescription drugs feature increasingly prominently in death certificates. And as I say, that there's a specific action in relation to that, tackling those issues in the strategy, and a commitment from the Health and Social Care Board to update the Prescription Medicines Action Plan so that we can drive down further inappropriate prescribing. But again, just to make the point that these drugs unfortunately are available on the internet. If we take another example, is benzodiazepine, we know that even reducing prescribing of benzodiazepines, as they have successfully done in Scotland, does not necessarily reduce the misuse or indeed deaths associated, because unfortunately these drugs are available on the street and can be. There's also diversion from legitimate sources as well. Gary, I don't know if you want to.
No, sorry. I have other members here. As we can't have 3 or 4 people answering questions, with all due respect. Yeah. If there's something to add that's absolutely relevant and particularly important and salient to the answer, I can't have 3 or 4 people answering questions. Frankly, I don't have the time for that. I have members here who have other commitments. So I don't mean to be prescriptive or guillotine the meeting, but I do have to keep the meeting on time. So if the other contributor's got something that's going to add to the answer, then that's fine. And I'm not suggesting it wouldn't be, but I would simply make the point, could I ask you please to be brief and succinct in answering the questions, because if 3 or 4 people are answering, it's very difficult to manage the meeting.
Chair?
Yes?
Chair, can I hear me? Yeah, okay, you had frozen there for a minute. Can I just point out one piece of information, just the North of Ireland is the highest per capita prescription of pregabalin within the UK. But once again, I just say, thank you ever so much for your answers to date.
Okay, in terms of that's obviously not what the Chief Medical Officer was saying. So in terms of the current, in terms of Wales, just a moment. Could I bring in Mr. Muir, please?
Thank you very much, Chair, and apologies for lateness today. Just 2 brief things. I think it's important when we're considering this inquiry to understand that there is other policy interventions that, and also legislative interventions that could and should have been made by this House over the last number of years, such as, for example, in relation to gambling addiction and in relation to alcohol pricing. So it's important to take that in the wider sphere. But my question is a more practical one, which is really in terms of an example of where we need to get the policy response from government better in relation to addiction services, which is in Belfast city centre. People have seen over the last number of years how things have developed in Belfast city centre and the impact that's had upon, most importantly, the individuals concerned, but also upon the traders and the general environs within Belfast city centre. And I just want to ask, particularly, and this has been particular during the pandemic, and people will be aware of the issues in relation to that and the very sad number of deaths that have occurred within Belfast city centre. The response to addiction needs to be a joined-up one from different statutory bodies, including the police, health and social care, and different organisations. My question really is to the witnesses: why has the situation been able to develop, and what more could be done to address that? Because this is a practical outworkings of this inquiry and the findings within it.
Thanks for that. I mean, my overview comment would be in terms of why has the situation been allowed to develop. I mean, I certainly wouldn't want to suggest, and I don't think it's your point you're making, that we have sat back idly and watched this develop. This is a societal issue, and society is changing, behaviours are changing, access to both illegal drugs is changing. Certainly, if you track the position in Northern Ireland, if you go back a number of years, there was very, very low levels of the illegal drugs, distinct from prescription drugs. That has changed. Fundamentally, the issue is, and I think it goes back to one of our very early discussion points, we need a cross-sectoral and cross-departmental approach to this. Well, to drive through Belfast city centre and to see problems, they're not necessarily health problems. The outworkings of those problems land very much at our door. I hope this is a sufficient answer. The work that is set out in the strategy with the vision and the outcomes is very much about driving forward that collaborative effort to try and bear down on those problems. We haven't been as good at that in the past, and there hasn't been a standoff, and Megan, you wouldn't have sensed that between different sectors not doing it, but there was a sense that one sector or another needed to grip this problem. What we're doing now is coming together to jointly grip these problems and try to take them forward.
Yes, and thank you. I'm conscious of the Chair's comments. I'll keep my comments succinct. I mean, I think that I referred earlier to the Doncaster model and the work being taken forward by Belfast City Council, PHA and Board in relation to that. I've attended a number of those multi-agency meetings involving PSNI, liaison officers, those on the streets, the street injector project, local government officers, those who are working very, very closely, community and voluntary sectoral organisations. So just to reassure you that that work is ongoing and does continue and has been in place for quite some time. The issues are around the access and availability of drugs and some of the issues which the report itself has pointed out about the age profile of users, and also because they're developing other health problems, etc. But also, despite the improvements that we're seeing at a population level, we are seeing very significant changes in risk-taking behaviour in terms of the harms, and that's manifest in terms of the number of deaths that we're seeing, and that's down to polydrug use and also to the hospitalisations that we're seeing. So, as Richard has said, the complexity has become much, much greater because of a variety of factors. But just to reassure you that that commitment to joined up working is already underway and is happening as we speak.
Thank you, and I promise the Chair a succinct question, so that's me done.
Very good. You're so disciplined. Mr. Boylan.
Thank you, Chair. I might sit at home the next time on Zoom. I might get in quicker for a question. But listen, I'd like to thank the people for coming along and making the presentation. And Richard, I'll take it as sold. You're saying the additional 6 million will be got in terms of helping deliver the strategy. But you may want to comment on that. But I have 3 key points. The first one is in terms of those people needing help directed to the right service. And clearly in the report it's saying the lack of awareness to Tier 2 services in some respects. So my question to you is how do you intend to ensure proper referral to those services in the future, those lower threshold services? That's my first question. Thank you.
Just on the 6 million, I would love to be certain we'll get the 6 million. I think the nature of budget settlements tends to be an overarching budget settlement in response to an ask that is comprised of many, many component parts. This will be a key component of our ask in the budget process. Budget settlements tend not to allocate money to every component, so there will, and the reality is it's unlikely that any department will get everything they ask for. So there will be a decision for the executive in terms of the allocation about prioritising, and then ultimately there will be a decision for the health minister about how he chooses to prioritise his resources when he sees the budget settlement. I think it's difficult to preempt that. All I can say is I know there's a strong measure of support at the executive for this. I know my own minister is committed to trying to do this, but equally there are a huge range of pressures on his desk at the moment, and it wouldn't be for me to preempt that. In terms, Brendan,
just in terms of Tier 2
services
in particular, just 2 quick points again, taking on the Chair's comments. One, there's a piece of work about making contacts count in primary care and making primary care colleagues more aware of all the services out there, and I do feel sorry for them because there is a plethora of services, so it's attempting to make that easier for them and do brief interventions with people in front of them. The second one is we've asked the PHA in particular to update their Drugs and Alcohol NI website, which has directory of service of all the services available in Northern Ireland. I think one of the challenges with the directory of services is people don't know they need the service until they're in crisis, and when they're in crisis they don't particularly want to go to a website to find that source of information and support. So it's also about making sure that our colleagues in ED or other key community groups or others are aware of those. So we'd really be happy to work with anybody, including elected members, to encourage awareness of the services that we have. One in particular I just want to point out is our family support services that are actually underutilised. And so really keen to push those out there available to any family member, whether their loved one is in treatment or not.
Thank you. My other point is in terms of the data quality and completeness. Why is it taking so long to address those issues in terms of data?
I think part of the issue has been the multitude of players in this, in terms of actually all working to the same standard, because ultimately if we want to utilise this data, it has to reach a certain qualitative threshold to be badged as a national statistic. I think we're a long way from that. There's a multitude of players, so it's a very, very fair comment, which we accept without reservation. Colleagues in the Audit Office have made, and outcome E in the new strategy is very much focused at governance, implementation and research, and trying to address this, just to get that quantitative information to try and underpin this.
No, and appreciate it, and they asked it obviously in the context of you develop a new strategy, and if you haven't got some of that data, it's very difficult. But I appreciate some of the answers earlier on in terms of working cross-department with other sectors, but the context of the question is you've developed a new strategy under the pretext of the data quality not being there. That's my key question,
No, and that's a fair point, but it's also just to make the point that the data where those qualitative issues lie at the moment is in many cases with organisations at sort of tier 1 and tier 2 level, which are outside our direct control. So it's difficult. We can absolutely be prescriptive with our own organisations, who tend to work on standard platforms, and we can issue standards. But when you're working with particularly voluntary community sector and other partners, it's more difficult to be prescriptive. So it's very much a dialogue and trying to continually nudge this forward. But as I say, they're fair comments about the data quality issues, and one that's going to be a subject of much focus moving forward.
Yeah, I appreciate it. Thank you for the answers. I know all the members want to get in, but thank you very much for your presentation.
Mr. Borland, let me reassure you that whether you be here in person or you join us virtually, you are called when you single, so it won't make any difference whether you're here or not. There is no impartiality or partiality. I think it is simply when people are called. Mr. Beggs.
Thank you, Mr. Chairman. I too would like to welcome the publication of the new strategy document, Preventing Harm and Empowering Recovery. The challenge, of course, will be in delivering on it. So, are you certain there will be the necessary cross-departmental support for that and full recognition? For instance, I was a bit surprised when I read the Audit Office report that actually the biggest cost of this is not the Health Service, but the Justice Department. So, are you confident of being able to implement improvements?
I am confident, but I don't think facing forward as we do, any of us can be certain. I think, I would emphasise our Minister in finalising this strategy took it to the Executive, so it has Executive support. As part of the governance arrangements for taking this forward, there will be a programme board that Michael will chair. We also intend to establish a cross-departmental ministerial group. So ministers have indicated they stand behind this and they support it. So we absolutely expect officials in terms of the programme board that Michael will chair to come to that with that in mind. We will work together. There will be an opportunity for ministers to have oversight and some governance arrangements in that. So I don't doubt for one second that everybody will come to this in the spirit of collaboration, seeking to work together. But as much as I will never fail to put down the marker about the intense financial pressure we face, I think my colleagues in the justice sector would similarly never miss an opportunity to identify the issues and pressures that they face. The point that Michael has made, we are absolutely in spend to save territory here. Every pound we spend on proper and effective implementation of this strategy will be reaped 4, 5, 6-fold down the line in terms of future savings and interventions in the justice sector and in the health and social care sector.
Okay, the Audit Office report also indicates that the majority of drug-related deaths involve prescription drugs. Is there an assessment how much of them are coming through via the National Health Service, or what percentage are coming from the black market?
Just obviously that's very difficult to determine on the basis of an autopsy and toxicology report. Certainly we know some of them are. If we look at some of the benzodiazepines that are named in deaths, they're actually ones that are not prescribed in Northern Ireland. They're a mixture of novel psychotropic substances and ones that are prescribed elsewhere. So it's very difficult to get an absolute breakdown on that given the way it's reported, but we definitely know that there are, some of those deaths will be prescribed drugs because they'll be prescribed considering treatment or in pain or in other issues that goes along with that, but certainly there are a range of substances that are also in there that are taken as part of a polydrug misuse sort of way of risk-taking and behaviour, so it's difficult to get an exact breakdown of which are prescribed and which are actually illicitly purchased.
Would you accept?
The dimension was back a thing called Operation Pangea. So it doesn't answer your question, but this was back in May 2021.
Yep.
I think approximately there was a cross-sectoral exercise to actually look at the importation of prescription drugs. Something like 94,000 tablets or doses were recovered in the mail that were destined for Northern Ireland. So that's just a fairly significant marker about and that was over the period of a week.
Yeah, about £100,000 worth of drugs on the black market include drugs like pregabalin, diazepam, again, those benzodiazepines that Gary has referred to that are appearing on death certificates. So quite a significant illicit and counterfeit market as well contributing to that.
But would you accept that when there's such high prescribing levels in Northern Ireland, that tends to normalise some of these drugs, and people think they're very familiar, they're safe, and there's also a potential risk of some people acquiring them to misuse them. For instance, 3.5 times as many prescriptions for diazepam per capita in Northern Ireland than in England. Is that a fair comment to make? That there is there's a risk of normalising these drugs and a higher risk of misuse?
I think there's a valid point in your comment. I think that there is no doubt that prescription drugs are misused because some regard them as safer to use, but no drug that isn't prescribed for you is safe to use. There is no doubt that the use of benzodiazepines, diazepam being one of those, is higher than other parts of the UK, has fallen as it has done in other parts of the UK. That's down to no small part from the efforts of the Health and Social Care Board in terms of monitoring returns to prescribers of drugs. But I think we need to put it in the wider context as well. We have 25% greater mental health needs in Northern Ireland compared to other parts of the UK. We have some of the highest levels of socioeconomic deprivation. Previous research by universities here demonstrated that your proximity to a peace wall was directly correlated and related to the rates of prescribing for anxiolytics such as benzodiazepine and antidepressants. So we're dealing with a legacy of a community that's coming out of conflict, and indeed we are still living in communities where we're still seeing some of the impacts of that conflict. So I think that, as Richard said earlier, we should not necessarily see equivalence between prescribing levels and as inferring that somehow or other that prescribing is inappropriate. But absolutely, what we do need to do is to ensure that we reduce the levels of those prescription drugs without any shadow of a doubt, and that involves providing alternatives as well in terms of some of the pressures that we have in mental health services. That involves alternatives to prescription drugs such as cognitive behavioural therapy, counselling, etc., which are equally important and can be as effective as prescription drugs.
On specifically who is doing the prescribing at the minute, I see under the shared care model in the Audit Report it states that GPs should be responsible for a significant part of providing care and prescriptions for stabilised service users. But in the graph provided there, it shows a huge variation from 3 to 30% of prescriptions being led by primary care. Why is there such variation? Who's actually doing the prescribing? Is it locums on duty on A&E giving a prescription and then just being maintained? Who is doing the prescribing? And why is the model not being followed?
I'm not looking at the... I think maybe we're conflicting two things here. I think what you're referring to, if I understand the question, is in relation to shared care in terms of substitute prescribing. And I think that's the particular diagram and reference that you're referring to in the report, and please correct me if I'm wrong. I think what that demonstrates is an absolute commitment to ensuring that there is a more uniform approach to shared care in terms of substitute prescribing across Northern Ireland, because again we know, and the Audit Office report quite correctly points to the pressures that we've had on substitute prescribing services over the last number of years. I think we also have to say that shared care is not appropriate in all cases. Certainly there are very complex, complicated cases such as substitute prescribing in pregnancy, those who have been discharged from the criminal justice system, for instance, who are particularly at risk at those transition points, and it is appropriate that those individuals continue to have their prescribing and management care continued in community addiction services.
I fully accept that, but my question was why is there such variation from 3% to 30% only being prescribed in primary care? That was the question.
Yeah, sorry, apologies. There is, I mean, you quite referred to, I think, 30% in the Northern Trust. I think you've also, what we also need to bear in mind, there's a difference in complexity in relation to drug misuse and some of the factors that we see, and indeed one of the other members referred to the particular problems in Belfast. We have some very chaotic drug misuse in the Greater Belfast area, compounded by a range of other problems, and again some individuals are less suitable for a shared care model. As you say, we have 30% in the Northern Trust. I think it's something like 14% in Belfast. Work was undertaken just before the pandemic to increase the number of individual GPs who are involved in shared care, because that helps drive up the knowledge and experience and expertise that Gary was referring to earlier. We had a Project Echo, which was a sort of basically telehealth, telemedicine support to those GPs, but that had to be put on hold during the pandemic, or the worst of the pandemic, and that work is now underway. But there is a commitment, as you quite rightly say, to increase that percentage of GPs who are involved in the shared care, but it isn't compulsory. I think there is no doubt that a lot of GPs have concerns. And indeed, there's an issue about providing the experience and the confidence to GPs to participate in that shared care model.
Why is it as low as 3% in the southern area if it's thought to be the right model to follow?
I can't answer that question. I don't know the specific details of why it's so low in the Southern Trust. Okay,
moving on to a different issue in terms of hospital bed days. Over the period 2014 to 2018, there's been about, I'm guessing, about a 35% increase in hospital bed days in Northern Ireland. But in the same period in England, there's been a reduction by 25%, and Wales a reduction by 9%. So what are they doing different? Because hospital bed days are expensive and not necessarily best for patients as well. What are they doing different that we're not doing? Have we learnt anything?
I think part of the issue in terms of any comparison between Northern Ireland and England or Wales or other places, we're in different points of the journey in terms of the problems we're encountering. And I think I touched on the fact earlier that if we go back, I think to 2015, the level of illegal drug availability in East and Northern Ireland was materially much lower than it is now. So I think part of the issue in terms of that comparison is that, you know, in the here and now, we're facing a slightly different problem than colleagues in England and Wales face. That's not to say that, you know, there aren't still lessons that we can learn, and again, part of the strategy is looking to experience and innovation and new developments in other places. But we're not always comparing like with like when we look at those comparisons with other jurisdictions.
Okay. Another question for Dr. McBride. In terms of, you referred earlier to alternatives to prescribing, and I fully support that idea. How is social prescribing developing? Because sometimes it's a much better long-term benefit to the patient than simply being given a tranquilizer. So how is social prescribing being developing? It was launched a few years ago, and it's an important alternative to prescribing medicines.
Yeah, and again, I know, Roy, that you didn't mean it sort of simply reaching for the prescription pad, because just to reassure you that no GP, simply reaches for the prescription pad when it comes to prescribing diazepam. And certainly, if we look at the Northern Ireland formula, we know that 77% compliance with the formula in relation to some of the CNS active drugs, and the formula only covers 80%. So we know that there is good compliance with the Northern Ireland formula here in terms of the prescription of those drugs. But you're absolutely correct. I mean, I think that there has been expansion. There needs to be further expansion in terms of social prescribing, whether that's in terms of individuals to be involved in other activities which improve their mental health and well-being. That's whether that's relation to them connecting with other people within their community, whether that's in relation to the benefits of physical activity, whether it's in relation to cognitive behavioural therapy to deal with some of the precipitators and triggers that have resulted in their alcohol or drug addiction. So we've made good progress. I don't think we've made as much progress as we would wish, and I think there's certainly much more to be done in that space.
Then finally, in terms of the importance of links to the community involuntary sector, who can fill a gap between the statutory sector, which is there. In the past, significant projects, and I'm thinking in terms of projects like the Hope Centre in Ballymena, which was jointly funded by Health and Justice and perhaps some other cocktails, was providing a vital service and greatly appreciated in the community. But sadly, because of an end of cross-departmental funding, they closed, and the expertise and that team were dispersed. So how is such community involuntary sector activity to be built up again?
I think, Roy, that's a real challenge across all sectors. I think I suspect over the last half a dozen or so years it has been of huge frustration to colleagues in the voluntary sector that there is oftentimes a tendency that when central government finds itself under financial pressure, one of the early moves is to look closely and scrutinise at funding flowing to the voluntary and community sector. In my experience, generally each pound that you give to the voluntary community sector levers in well in excess of £1 in value in terms of the other issues that colleagues in the voluntary community sector bring to the table. I think what we've put at the heart of this strategy is that collaborative approach. That's something we wanted to refresh and renew and work on. It will have to be done in the context of very, very pressurised budgets, but I think the point you make is a very strong one, that sometimes the best services at local level are those that have a very, very strong local dimension through colleagues in the third sector. I think we need to redouble our efforts in terms of how we work with them on a mature basis, how we engage with them, and how we lever out some funding for them, because in my experience, they're a really, really strong value proposition from colleagues in that sector.
Okay, thank you.
Okay, Mr. Irwin.
Thank you, Mr. Chairman, and thank you for your presentation. And I'll be brief. I mean, I'm not the expert on this, but the concerning thing for me is that the level of harm caused by substance misuse is high, but the bigger concern is it's still rising. So it's evident to me that in the past, any strategy you have has not worked. Are you confident that this new strategy will make a difference?
The short answer is yes. I have no doubt that this strategy will make a difference. If we sharpen your question, am I confident that this strategy will turn the tide and start reducing the numbers? I don't think society will allow us to be in that position. The numbers have increased over years. It would be a matter of some conjecture. What would the numbers be had we not been working on the strategy? As Michael said, the review of our previous strategy showed that something in the region of 80-odd% of the actions in it were either delivered or were on track for delivery. So I think I am confident we have made a very significant contribution towards improving this place. The challenges, the societal challenges, and we're all aware, and members of the committee more so than me, in terms of the work they do at community level. The pandemic will make the landscape all the more difficult and challenging in the months and years ahead. So yes, it will make a difference, but I do think we're in the territory, Michael, of reducing rather than reversing the trend for the short term.
No, I think that's a very fair comment, and I think that we look to what's happening in other parts of these islands with significant concern. If we look at the situation in Scotland, for instance, some other parts of England, very strong links to socioeconomic deprivation, and none of us want to get to that situation. So, as Richard has said, we certainly had a very significant progress on the actions within the last strategy. I'm confident with the same commitment, and particularly with the excellent working relationship that we have with the community and voluntary sector, who have really been key partners in this, and that commitment to share responsibility, co-production and collaboration, and equal partners in this. And I think one of the things which I would also point to is the fact that the strong user voice that we have at every level in the strategy, we had in the last strategy, and we will have in this strategy, and that actually keeps it real and keeps us focused on the things that really are important. And actually, in terms of responding to your question, gives us feedback about the things that are working and the things in the system, quite frankly, that aren't working and need to change.
Okay.
Okay, thank you very much. Thank you, Mr. Irwin, yes?
That's okay.
Yeah. Thank you very much. I think every member who's indicated they wish to ask a question has done so, and I want to thank you for coming today. I think the point, Mr. Pignelli, that you make at the end about the pandemic and the negative effect that societal effect that has had, not just on our nation's health, but in terms of mental health and societal challenges, is and will be immense, and perhaps it will only be in the ensuing years that we will see that challenge. I very much agree the point about costs and the opportunity cost of not having that early intervention, and in terms of having the strategy to deal with the thing and the challenges proactively. That all having been said, I welcome the buy-in from the executive, but the old saying, talk is cheap, it takes money to buy whiskey. If we don't have the extra £6 million per annum that you're needing, what happens to strategy?
The reality is the strategy will probably remain partially implemented, but I think it's important to say it will be partially implemented. There are elements of this strategy we absolutely will take forward without any additional funding. It'll be reusing money we have. So it's not all or nothing. We'll end up in a partial implementation.
But holistically, in terms of the strategy and the challenges that you want to face and meet in society, that would be much more problematic if you don't have that £6 million.
It will, yes, but
Yeah.
equally, I mean, I suspect in another day, Chair, we could be talking about another issue, and there will be that issue will be every bit as emotive, and will have the same financial challenges. This is about trade-offs.
I understand. Look, at the very outset of your comments, you mentioned about the committee and that we request you coming in November of last year. We took a decision that the committee should act responsibly given the challenges that you faced and Dr McBride, as he was then, faced, and we appreciate the work that has been done since then. It's so tragic that so many people have lost their lives, and however, if we hadn't had the rollout of the vaccination, no doubt we would have probably looking at much more challenging figures. So I just want to thank you as the Permanent Secretary and Sir Michael as the Chief Medical Officer for the leadership that you've given. We absolutely faced unprecedented challenges in the most difficult of times, and we continue to face those challenges. And the only way they will be dealt with or eradicated is if we all work together and people act responsibly. So I listened very carefully to the presentations that were made and the answers given, and I really do hope that the strategy is funded and implemented in full in terms of improving the lives of our people and improving society. So thank you all very much, all four of you gentlemen, for your time this afternoon. Thank you.
Thank you, Chair.
Okay, members, so with your permission now, we will go into closed session to discuss the evidence session.
This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound.